Good afternoon, everyone, and thank you very much for joining us. Stopping Ebola is hard. We're working together to make it safer and easier. Yesterday, we confirmed the first case of Ebola contracted in the United States in a healthcare worker who cared for who we refer to as the index patient in Dallas, Texas. Our thoughts are with this healthcare worker. She is now being cared for, and we understand that she is clinically stable. Please refer any questions on her care to the hospital where she's being cared for, so that only information that she and her family want released is released. The existence of the first case of Ebola spread within the U.S. changes some things, and it doesn't change other things. It doesn't change the fact that we know how Ebola spreads. It doesn't change the fact that it's possible to take care of Ebola safely. But it does change substantially how we approach it. We have to rethink the way we address Ebola infection control, because even a single infection is unacceptable. I'll get into some details of what we're thinking about with regard to how to make care even safer in a minute, but I want to just step back first and outline what we're doing and what the current status is. First, before the index patient in Dallas was hospitalized and isolated, there were 48 potential contacts, 10 known to have contact with him, 38 who may have had contact with them. All of those 48 contacts have been monitored daily. None of them have developed fever or other symptoms as of now. This is consistent with what we know about Ebola, that people aren't sick when they don't have symptoms, and the sicker they get, the more infectious they may become because the amount of virus in their body increases. Second, for the healthcare worker who was diagnosed yesterday, we have been discussing with her. Our team lead in Texas has spoken with her on multiple occasions. She's been extremely helpful, and we have identified one and only one contact who had contact with her during a period when she was potentially, although likely not, infectious, because it was at the very onset of her symptoms. That individual is also being monitored and as of now has no symptoms suggestive of Ebola and no fever. Third is to identify the healthcare workers who also cared for the index patient and ensure that they are actively monitored for development of symptoms or fever, and if they develop either symptoms or fever, that they're immediately isolated, assessed, and tested. That process is still underway. The team worked hard through the day yesterday, into the night yesterday, and are still actively working today to interview each one of the large number of healthcare workers who might potentially have had contact with the index patient when he was hospitalized. And the thinking here is straightforward. If this one individual was infected, and we don't know how, within the isolation unit, then it is possible that other individuals could have been infected as well. So we consider them to potentially be at risk, and we're doing an in-depth review and investigation. So these are the three categories of contacts. Contacts with the index patient before he was hospitalized, contacts with the healthcare worker who was diagnosed yesterday, and contacts who may have also had contact with the index patient after he was hospitalized. All of them will be actively monitored, and that's how we break the chain of transmission. We prevent another generation of spread of Ebola. In addition, as I indicated yesterday, we are doing a detailed investigation to better understand what might have happened with the infection of the healthcare worker. We look at what happens before people go into isolation, what happens in isolation, and what happens when they come out of isolation. And we're particularly concerned with that third process, taking off the isolation personal protective equipment, because if it is contaminated, there's the possibility that a worker will contaminate themselves and become infected in that process. From day one, we've had a team on the ground in Dallas working closely with the hospital, the state, and the local health officials. When the additional patient was diagnosed, we doubled down and sent an additional team in place. That team has been at the hospital just about continuously since. They've been working through the night. We're not just doing an investigation, we're immediately addressing anything that could potentially make it safer and easier to care for people who have or may have Ebola. We're not going to wait for the final results of that investigation, and I can go in some detail later to what we are doing in the short run, but each time we identify a process or training or equipment or protocol that can be improved there, we are improving it right there on the site. I want to clarify something I said yesterday. I spoke about a breach in protocol, and that's what we speak about in public health when we're talking about what needs to happen. And our focus is to say, would this protocol have prevented the infection? And we believe it would have. But some interpreted that as finding fault with the hospital or the healthcare worker. And I'm sorry if that was the impression given. That was certainly not my intention. People on the front lines are really protecting all of us. People on the front lines are fighting Ebola. The enemy here is a virus, Ebola. It's not a person, it's not a country, it's not a place, it's not a hospital. It's a virus. And it's a virus that's tough to fight. But together, I'm confident that we will stop it. What we need to do is all take responsibility for improving the safety of those on the front lines. I feel awful that a healthcare worker became infected in the care of an Ebola patient. She was there trying to help the first patient survive, and now she has become infected. All of us have to work together to do whatever is possible to reduce the risk that any other healthcare worker becomes infected. When we think about hospitals where Ebola care can be given, really there are two different steps. The first is diagnosis. And every hospital in this country needs to think about the possibility of Ebola in anyone with a fever or other symptoms that might be consistent with Ebola who's traveled to any of the three countries, Liberia, Sierra Leone, and Guinea, in the previous 21 days. Whatever else we do, that's critical throughout our entire healthcare system so that patients are rapidly diagnosed if additional patients become ill in this country. Second is the issue of care of Ebola once the diagnosis has been made. I think what we recognize is that that care is complex, and we're now working very closely with the hospital to make that care simpler and easier with hands-on training, hands-on oversight and monitoring. And that's something that we will do anytime there is a case of Ebola. Now, I want to just end, before I turn it over to Commissioner Lakey, with thinking a bit about what comes next. What's going to be happening in the coming days and weeks? Well, first is the safe and effective care of the healthcare worker in Dallas. And we will do everything to make sure that those who are taking care of that individual are doing so while protecting themselves, and that that individual gets the best possible care. Second, as I said yesterday, we need to consider the possibility that there could be additional cases, particularly among the healthcare workers who cared for the index patient when he was so ill. That's when this healthcare worker became infected, and we're concerned and would unfortunately not be surprised if we did see additional cases in the healthcare workers who also provided care to the index patient. Third, we will continue to track all contacts, all of the 48 from the initial patient's exposures before he was hospitalized, the one individual who was exposed to the healthcare worker who's hospitalized now, and all of the healthcare workers who may have been exposed during the initial care of the index patient. Fourth, we'll work with hospitals throughout the country to think Ebola in someone with a fever or other symptoms who has had travel to any of the 3 affected countries in the previous 21 days. And fifth, we will double down on training, outreach, education, and assistance throughout the healthcare system through professional associations, through hospitals, through group organizations and individuals, reaching out to health departments at the state and county levels in cities and elsewhere, so that we can increase the awareness of Ebola and increase the ability to respond rapidly. We wish the situation in Dallas were different than it is today. We wish this individual had not been infected, and we're concerned that there could be other infections in the coming days. But what we're doing now is implementing an immediate set of steps that will ensure that the care of that individual is safe and effective, while we look longer term at what this implies for what we should be doing to care for Ebola as safely and effectively as possible wherever it may arise. And with that, I'll turn it over to Dr. David Lakey, who is Commissioner of the Texas Department of State Health Services.
Thank you, Dr. Frieden, and thanks everyone for being part of this briefing today. Obviously, it's been a very tough several days here in Dallas. Very tough day and last several days for the hospital staff. And we knew it was a possibility that one of the healthcare workers would become infected, but it's still very disappointing. And I know the family is possibly listening, and so I want them to know that our thoughts and prayers are with them, with the healthcare worker, and with the staff that are working hard on her care right now. There's many components to our response here in Dallas. Dr. Frieden talked about many of those components. Our top priority right now is the contact investigation. It's hard work. A lot of work is taking place. We've pulled in additional staff from throughout the state of Texas, complementing the work of the CDC and the Dallas Health Department's staff. And so we're bringing in the resources to do the contact investigation from many different levels of government to identify those individuals and contact them as quickly as possible. Dr. Frieden talked about infection control, obviously a critical component of this response. Looking hard at the infection control practices and making sure that they're even more stringent than what they are right now, and have CDC experts, the best in the field here in Dallas, working with us to make sure that we are as stringent as possible with infection control. The healthcare workers' apartment, initial cleaning has been done. Additional evaluation and cleaning will be accomplished today. We're doing this with local leaders, but also with other state agencies to make sure that we do that in accordance with the best guidance that's out there. One issue related to the final cleaning is the healthcare worker had a dog, and we want to make sure that we respond appropriately. And so we're working hard to find a location to care for the dog and a location where we can have the proper monitoring of the dog. And finally, the work that we're doing is contingency planning. Again, we know the possibilities that can occur, and we want to be prepared. And so a lot of work is taking place right now with a variety of healthcare providers, emergency managers, EMS, to make sure that we are ready for whatever needs to take place. And at the same time, following the folks that we know have been contacted, and the 48 individuals that we've been monitoring so far, and the additional individuals that Dr. Frieden has discussed today, making sure that all of them know what needs to happen if any of them start having symptoms. And so, again, a lot of work is taking place here in Dallas, and we continue to be grateful for the support from the CDC and our many other partners in this response. And with that, Dr. Frieden, I'll hand the line back over to you. Thanks.
Thank you very much, Dr. Leahy, and thank you for all that the team there is doing in Texas. It's an excellent working relationship, and we value it greatly. Before turning to questions, I'll just comment that the situation is fluid, and we will continue to update you as we get more information. In the room. Oops.
Doctor, you spoke about the possibility of further infections. Is that because there's a known safety procedure or protocol that perhaps was not followed? And my follow-up question to that is, if you cannot pinpoint the breach in protocol, how do you move forward with education?
If we knew that there was a specific incident, such as a needle stick, that would indicate that we could narrow down the healthcare workers at risk to those who had that specific exposure. Since we don't know what the exposure was, though we know there was an exposure, then we have to cast the net more widely and see, in terms of monitor a larger proportion of the healthcare workers, and in terms of infection control protocols or procedures, improve every aspect of those procedures every time we see something that could be improved. So, for example, our staff there now are watching as patients put on and take off all of their protective garb. They're retraining staff in how to do that safely. They're looking at the types of personal protective equipment that are used to see if there are some types that might be easier to put on or take off and thereby reduce the risk that someone would unintentionally contaminate themselves. We're looking at what we do when someone comes out of the isolation unit and possibly spraying them down with a product that would kill the virus if there is contamination. That was already in our guidelines for gloves, but we're looking at that more broadly. We're also looking at things that can be done within the isolation facility to reduce the risk that individuals' personal protective equipment could become contaminated with the Ebola virus. So there are a series of things that are already implemented in the past 24 hours, and we will continue to look at that in terms of how can we make care easier and safer.
Hi, it's Marian Falco from CNN. You have been telling us about what needs to be done and how prepared we are for months now. You've been telling us for a long time about the risks and all the things that can be done. But you just said that you're working at making care simpler and you're providing hands-on training. It seems like there's a gap in what you may have thought was happening at the nation's hospitals and what actually is happening. Have you thought about bringing in somebody like Doctors Without Borders, which has been successfully treating patients in Africa for years, to learn about how they do it? And then the second question I have is regarding the travel. You have said multiple times that travel ban is not helpful for many reasons, but many people still think, why not keep those people who may be sick from coming into this country? Can you better explain why you don't think a travel ban is a good idea?
Sorry, your first question again?
The training about...
Training, thank you. We've worked very closely with Doctors Without Borders, MSF. In fact, we've replicated their training course, and we have dozens, soon hundreds of U.S. doctors and other healthcare workers who are going to Africa to fight the outbreak at the source, going through a CDC-run training program that replicates the training that MSF has done. The same team at CDC who created that training course is training physicians throughout the U.S., but definitely we will be looking over the coming days in how we can increase training and increase training materials and availability, most urgently for the healthcare workers caring for the patient in Dallas, but also more generally throughout our healthcare system. It is worth highlighting that the single most important thing for every other hospital in the country to know is the importance of taking a history of travel. That if someone has fever or other symptoms that could be Ebola, ask where they have been in the previous 21 days. And if it's to Liberia, Sierra Leone, or Guinea, then immediately place them in isolation, consult with us and the state and local health department, and we'll go from there. But that's what the healthcare system in general needs to really focus on. In terms of travel, we're looking at multiple levels of protection. The first is screening of people on departure from these three countries. All are screened with a questionnaire, all have their temperature taken. 77 people in the last 2 months were not allowed to board, not allowed to enter the airport even, because they had fever or other symptoms. None of those were diagnosed with Ebola. Many of them had malaria. In addition, starting yesterday at JFK International Airport in New York City, we began screening people who came from these countries, these 3 countries, also with a detailed questionnaire and temperature check. Since that was implemented, 91 such individuals were identified. None of them had fever. 5 of them were referred for additional evaluation by CDC. None were determined to have exposure to Ebola. So this is in place at JFK. Thursday of this week, we anticipate having this in place at 4 additional airports in the U.S., and we'll learn from that experience. Also, making sure that doctors throughout the healthcare system diagnose Ebola promptly is very important. On the issue of banning travel, I understand that there are calls to do this. I really try to focus on the bottom line here. The bottom line here is reducing risk to Americans. The way we're going to reduce risk to Americans is do the steps of protection I just went through and stop it at the source in Africa. Today, CDC has 150 of our top disease detectives throughout the 3 countries and many of the counties, districts, and prefectures within the 3 countries helping to turn the outbreak around, working along with the Department of Defense, with USAID, with the World Health Organization, and with many other governments which are surging in to help stop it at the source. If we do things that unintentionally make it harder to get that response in, to get supplies in, that make it harder for those governments to manage, to get everything from economic activity to travel going, it's going to become much harder to stop the outbreak at the source. If that were to happen, it would spread for more months and potentially to other countries, and that would increase rather than decrease the risk to Americans. Above all, do no harm, and that's why we want to focus on stopping the outbreak at the source and protecting Americans wherever Ebola may arise, even though we know that that can be challenging.
Hi, Misty Showalter with CBS News. Texas Presbyterian is a relatively large hospital and still had a breach like this. Do you still feel confident that smaller hospitals can handle and isolate a patient with Ebola symptoms?
We're going to look carefully at the issue of what's the optimal way to safely, effectively care for people with Ebola, but I would reiterate that whatever we do on that issue, it's very important that every hospital be prepared to diagnose someone with Ebola. Remember, there may be Americans who've deployed or traveled to the area who come back. So whatever we do, we're not going to eliminate travel from these countries.
I understand is what Doctors Without Borders uses in West Africa.
Actually, the hospitals that have treated patients with Ebola in this country have all used what are called PAPRs, or positive air pressure respirators. That is a form of respiratory protection. That is clearly not how the individual in Texas became infected. So I don't think we have concerns about the potential route of transmission, but our guidelines already say that if there's any concern for aerosol generating procedures, such as intubation of a patient or suctioning, then absolutely we recommend respiratory protection. On this side of the room.
Hi, Ariel Hart with the Atlanta Journal-Constitution. 2 questions. First of all, can you clarify about the breach in protocol? Are you deducing that a breach in protocol must have happened because of the result, or have you identified any particular breach in protocol? And second of all, back in August, the CDC held a conference call helping clinicians prepare for Ebola. And your folks were pressed again and again by the clinicians about negative air pressure rooms and about what kind of garb to use. They seemed to think that, shouldn't there be some kind of indication for leg protection? And again and again, the CDC folks came back with up to hospital policy, stuff like, as for head coverings, we do not specifically call this out. Do you still stand by that guidance, or is there anything you would change?
And again, your first question was?
The first question was about the breach in protocol.
Yes. We have not identified a specific problem that led to this infection. We have identified a series of things where we can make the care safer and easier for the healthcare workers who are providing it. One of the things that's very important is that we have practical solutions that are workable. When you're taking care of a patient with Ebola, you need to go in and come out multiple times. Doing that in a way that works for you is very important. We're looking at what are the ways to do this most safely and most easily. One of the things that we found is that sometimes healthcare workers may think that more is better, so may put on additional sets of gloves or additional coverings, and that may actually end up paradoxically making things less rather than more safe, because it may be so difficult to remove those levels or layers that it inadvertently increases risk. We don't know that that happened here, but that's one of the things that we've been addressing. Even before the individual's infection, we had improved some of the infection control practices at the hospital. Over the past 24 hours, we've undertaken a series of improvements, and we'll continue to look at, as we investigate, every possible way to increase safety for healthcare workers.